The cervical plexus block is a simple technique that packs a punch. It's a useful adjunct for a number of surgical procedures, and in this video we'll discuss the anatomy, sonoanatomy, indications, and technique for cervical plexus blockade. The cervical plexus is formed by the ventral rami of C1 through C4. These roots form a plexus that lies deep to the prevertebral fascia, giving rise to a number of important branches that innervate structures in the neck and trunk. At this deep layer, the plexus gives rise to a number of muscular branches, including those to the infrahyoid or strap muscles of the neck. Most of these come off the loop-like ansa cervicalis. The cervical plexus also innervates the prevertebral neck muscles and provides sensory and proprioception to the sternocleidomastoid and trapezius muscles. Along with the brachial plexus, the cervical plexus co-innervates the levator scapulae muscle and the anterior and middle scalenes. Another important nerve that comes off the cervical plexus is the phrenic. It has its origin in C3 and 4, along with a branch from C5, and runs down the anterior surface of the anterior scalene muscle to enter the chest, where it innervates the diaphragm. A slightly important nerve. Now, if we look more superficially, we find the terminal branches of the cervical plexus, which comprise 4 sensory nerves. These are derived from the ventral rami of C2, 3, and 4. The C1 is effectively just a motor branch. And all of these emerge from the posterior border of the sternocleidomastoid, which will be important when it comes time for planning the block. We see the superficial platysma muscle here as well. The lesser occipital nerve runs up the posterior border of the sternocleidomastoid muscle to supply the posterior scalp and a portion of the external ear. The greater auricular nerve provides sensation to the skin of the face that overlies the parotid gland, as well as the lower part of the external ear and skin over the posterolateral scalp and mastoid process. The transverse cervical nerve supplies sensation to the anterior neck as well as the skin over the manubrium. And finally, the supraclavicular nerve supplies the skin over the supraclavicular fossa, clavicle, upper chest below the clavicle, and the sternoclavicular joint. Here's a schematic showing the skin innervation of the 4 sensory branches of the cervical plexus. You can appreciate it's a broad swath of important real estate. Let's look at this a different way by considering how the cervical fascia compartmentalizes the neck. Here we see a cross-section with a number of muscles and other important structures. There are 2 layers of deep cervical fascia that interest us for this discussion. The more superficial one is the investing fascia, which encircles the neck, splitting to contain the sternocleidomastoid and trapezius muscles. Deep to that is the prevertebral fascia. This binds the deep muscles of the neck, including the scalenes, to the vertebrae of the cervical spine. Now, the cervical plexus originates deep and terminates in the subcutaneous tissues, so there are options for block location. The deep approach involves depositing local anesthetic deep to the prevertebral fascia, adjacent to the transverse processes. The superficial approach, which is our focus here, involves depositing local between the investing fascia and the prevertebral fascia. Note that the plexus can also be blocked by injecting subcutaneously. There has been debate about nomenclature and a description of an intermediate cervical plexus block, but for our purposes, we're going to consider the first 2 seen here as deep and superficial. So, what does the deep cervical plexus block offer that the superficial one doesn't? Well, for one, a chance to consult a vascular surgeon. The deep approach involves touching a needle to the transverse processes of C2, 3, and 4, or some combination of those. The vertebral vessels run right through these processes, and it was not unusual for arterial blood to be aspirated when this landmark-based technique was done in the past. The truth is, there's no sensory block advantage to the deep approach. The only additional nerves you block going deep are the motor branches to the strap muscles of the neck. Fortunately, we don't need these blocked for any of the procedures we're doing this for, so it's not surprising that the deep cervical plexus block has become a footnote in the regional anesthesia history books. This block is commonly used to provide surgical anesthesia for carotid endarterectomy rather than performing a general anesthetic. It's also an excellent adjunct for thyroid or parathyroid surgery, excision of branchial cleft cysts, lymph node dissections, and for surgery on the shoulder, breast, or upper chest. It's also a really kind thing to do when you're putting an 8.5 French catheter into a patient's neck while they're awake. Clavicle surgery is a special case. There's been some confusion at times about how best to anesthetize patients undergoing these procedures. It turns out that the clavicle is co-innervated by the cervical and brachial plexus. The medial part is from the fibers originating from C3 and 4, namely the supraclavicular and transverse cervical nerves, and the lateral portion is from the various branches of the brachial plexus that originate from the C5 and C6 roots. Remember that the skin overlying the clavicle is also innervated by the cervical plexus, and for that reason, clavicle surgery can be done by performing an interscalene brachial plexus block and cervical plexus block. This is our go-to for clavicle fracture repair in our institution. Double plexus block plus sedation. Just remember that with some clavicle injuries, the brachial plexus can be affected, and so a good pre-op history and exam is warranted. We typically do this block with the patient supine or lateral. A linear transducer is placed on the anterolateral neck at about the midpoint of the sternocleidomastoid muscle. The needle will be advanced from lateral to medial. Here's a sonogram showing the relevant structures. We see the sternocleidomastoid muscle enveloped by the investing fascia and the anterior and middle scalenes below the prevertebral fascia. This plane between them is our target, where the branches of the cervical plexus live, having just emerged from deep to the prevertebral fascia. With the right patient and a high-frequency probe, you can often see the small nerves in this plane. Here's one of the branches here. We also see some superficial veins, so be careful not to hit the external jugular on the way in. You'll lose style points. The needle will be seen advancing from lateral to medial. The needle is advanced through the skin and the tip visualized. Note that our target is shallow, only half a centimeter, so take care not to advance too far initially. The needle is advanced under the posterior border of sternocleidomastoid and a test injection performed. You want to see that injectate between the two muscles, not intramuscular. We continue to inject and advance the needle slightly into the puddle of local that we've created until we see a nice separation of the SCM from the anterior scalene. This injection looks like a lot, but it's only 5 mils. A total of 5 to 8 milliliters is all you need for this block. The needle is then withdrawn. The superficial cervical plexus block is simple to perform, safe, and is effective for providing anesthesia and analgesia for a number of surgical procedures.